today we are going to discuss one very important topic which has been asking in AMC nowadays from last 6 to 7 months, that is Behcet Syndrome. Okay, so I downloaded the therapeutic guidelines. Okay, so we directly read from the therapeutic guidelines. Okay, so Behcet syndrome is a systemic vasculitis of unknown etiology that affects the arteries and veins of all the size associated with manifestation in the skin, mucosa, eyes, joint, GI, and CNS system. Okay, so I will let you know which questions they have been asking, and I have the pool of questions, recall questions. Okay. Vascular complication, thrombosis, and aneurysms are characteristics of this syndrome. The syndrome has a higher prevalence in the Middle East and Far East Asia, and geographical difference in disease expression exists. The onset of Behcet syndrome is the most common in people aged 20 to 40 years. Okay, and it affects males and females equally. However, males tend to have more severe disease. Disease severity commonly decreases over time. So it's most common high prevalence in Middle East and Far East Asia, like Turkey and these Japan people. So in the scenario, they have been asking about Korean, Japanese. So remember that. Okay. Clinical features, very important. Clinical features. Just give me a second. Okay. Okay, the diagnosis of Behcet syndrome is made on history and clinical examination. Remember that history and clinical examination. Refer patient to specialist for confirmation of diagnosis if Behcet syndrome is suspected. Okay, internationally recognized criteria exists. A point scoring system based on clinical features can be used to assist diagnosis. In this point scoring, whereas skin lesions, neurological features, vascular features, a positive pathology test, each score 1 point. A point who scores 4 or more points is classified as having Behcet syndrome. Okay, the most common clinical features, which is the most important thing in this topic. Okay, recurrent painful oral ulceration, recurrent painful genital ulceration, aphthis, like ocular inflammation, particularly severe uveitis and retinal vasculitis. Cutaneous lesions, characteristics of Behcet syndrome, for example, acneiform lesions, erythema nodosum. But in exam, they have been giving these three clues. These are the most important clues they have been giving. Okay, most important, remember that. Recurrent painful oral ulcerations, recurrent painful genital ulcerations. Okay, orogenital, they are using orogenital ulceration, and they have been asking that recurrent orogenital ulceration. Now this time the patient present with red dye as well, painful red dye. So in uveitis they will mention the painful red dye, scleral injection, severe pain. This is how they present in the scenarios. Okay, and orogenital ulceration. Okay, and they never give these clues, never give that clues. Yeah, in 2026 June they confused us with what you call the psoriatic arthritis, because in psoriatic arthritis we have orogenital ulcers, and we have arthritis as well, but we don't have what you call uveitis in psoriatic arthritis. Okay, but not recurrent or ulceration and genital ulceration we can see in psoriatic arthritis. So try to confuse her. So always remember that whenever you see the recurrent painful oral ulceration like orogenital ulcers, always think about Behcet syndrome, always think about Behcet syndrome. And in the MCQs they have given only these three clues, and nowadays only orogenital clues and arthritis. Orogenital clues, arthritis, then Behcet syndrome, because in psoriatic arthritis they have to give us the history of rash as well, right? Psoriatic rash, ciliary rash, because in Behcet syndrome we have the erythema nodosum as well. Okay, so please don't be confused. So read about the other things. Vascular features, vasculitis, phlebitis, aneurysm, positive pathology test, nothing that is uncommon in the Australian patient population. Noting that this is uncommon in Australian patient population. Okay, so forget about that. What is positive pathology test? In these tests, they put some, they just inject the needles. They prick with the needles our skin. They prick with the needles, and then they notice that we in Behcet syndrome patients they have definitely because it's autoimmune disease, so they have the exaggerated skin response, so it becomes a lumps within 24 hours, so it shows that it's a positive test. But even if it's negative, still we cannot exclude Behcet syndrome. Okay, mono or oligoarthritis. Okay, and arthritis in Behcet syndrome, it's a non-erosive, but in psoriatic arthritis, it's erosive. It's erosive. Remember that. Recurrent painful oral ulcerations, genital ulcerations, ocular inflammation, uveitis. Uveitis, orogenital ulcers. Go for Behcet. Go for Behcet. Don't think about other things. Okay. Uh, okay, so most of the time they asking about the diagnosis. So here they explain about those features as well. Frequent painful oral genital ulcers are the most common clinical feature. This is the most common clinical features of Behcet syndrome. Oral abscess canker sores are round and range in size a few millimeter to centimeter. They mostly appear on mucosa of the cheeks, lips, tongue, and gingiva, and there are no scarring. Genitalia apti are similar in appearance to oral abscess apti and most commonly occur on scrotum in males and uvula in females. Okay, genital ulcers commonly result in scarring. Herpes simplex virus infection is a differential diagnosis of recurrent Behcet syndrome. They never ask about that differentiation actually. They want us to differentiate it from psoriatic arthritis from SLE. So remember that psoriatic arthritis from SLE, and then when they give us the eye clues, don't be confused with other conjunctivitis. We have to differentiate for conjunctivitis as well. Okay, always consider coexisting HSV infection in people with oral genital ulceration, even if the recurrent episodes of Behcet syndrome is likely. Okay, but still we have to think about it. Ophthalmic features, severe uveitis occurs commonly in Behcet syndrome. It is usually bilateral and can affect both interior and posterior chambers of the eye. Retinal vasculitis, vascular occlusion of optic neuritis can occur frequently. Left untreated, ocular inflammation may irreversibly impair vision and progress to blindness. Okay, so we have to treat it. Otherwise, what we gonna okay, herpes simplex uveitis is differential diagnosis for uveitis associated with Behcet syndrome that must be actively excluded. Conjunctivitis, cyclitis, epicyclitis, and Zika syndrome are uncommon in Behcet syndrome and should increase the suspicion of alternative diagnosis. No need to memorize this. Okay, cutaneous features of Behcet syndrome they never ask in the scenarios, but for your information, erythema nodosum and acneiform lineage they also present in this way. So remember this papulopustular and pyoderma gangrenosum. A pathology test characteristics of Behcet syndrome in some parts of the world. It is uncommon in Australia, so don't remember it if it's uncommon in Australia. As we already mono and oligoarthritis, in it is mild and non-erosive. Okay, as I told you earlier, affects the knees, ankle, wrist, and lower back, and it's self-limiting of short duration up to 2 months, although chronic arthritis can occur. Vascular features include thrombophlebitis, DVT, hepatic vein occlusion. We can also get Wood-Cherry syndrome, superior inferior venous occlusion. They never ask about these things, okay? They never ask about these things. Okay, neurological features, what they ask, they never ask about the neurological symptoms as well. They just, because it's a disease which is always ignored by the doctors. So that is why they have been focusing this disease that we have to get the basic idea. That is the most common presenting symptoms for both. In have a single acute attack and having relapsing and emitting chronic progressive causes. Okay, not so important. Okay. GIT features. GIT ulceration in Behcet syndrome can cause colicky, abdominal pain, nausea, vomiting, diarrhea, and bleeding. Mimics inflammatory bowel disease. There are so many differential diagnoses for gastrointestinal symptoms associated with Behcet syndrome. So, gastrointestinal involvement require endoscopy confirmation. Refer to gastroenterologist if endoscopy is needed. Most patients with GI symptoms have mild disease course, although life-threatening complications such as intestinal perforation, perianal enterocolic fistula, and intestinal bleeding can occur. Investigation, there is no specific investigation that confirms the diagnosis, as we already discussed. If Behcet syndrome is suspected on clinical features, refer patients to specialists. Diagnose Behcet syndrome based on clinical features. Okay. ESR/CRP is elevated, and aspiration of synovial fluid from joints affected by arthritis Behcet syndrome most commonly reveals sterile inflammatory fluid. Other investigations include radiology, biology are dependent on the clinical presentation. Not so important, not so important. Management, very important. They have been asking about the eye involvement. Whenever you see in the scenario eye involvement and the orogenital ulcers, then okay, you diagnose with Behcet syndrome. But if eye is involved, always give oral steroids. Oral steroids, always give oral steroids. Remember. Okay. Okay. Some features, for example, oral and genital ulceration arthritis can be managed in primary care. Colchicine has been mainstay of treatment for Behcet syndrome but is now limited to management of further mucocutaneous features and arthritis. Immunomodulated drugs are preferred for organ-related features of Behcet syndrome. Immunomodulated drugs. Okay. So the thing is, first of all, we have to need the specialist management. The overarching aim of treatment is to improve quality of life by suppressing inflammation and preserving organ function while minimizing drug-related toxicity. As the features of the disease usually subside over time, treatment may be tapered or even stopped over the course of the disease. Some features, for example, oral and genital ulceration, arthritis, can be managed in primary care. Colchicine has been a mainstay of treatment for Behcet syndrome, but now it's limited for mucocutaneous features and arthritis. Before that we give, but now it's limited role. Non-pharmacological strategy for oral genital ulcers, oral hygiene, that is soft toothbrush to reduce plaque, and non-alcohol based mouthwash recommended. Topical treatment, okay. Topical treatment for oral genital ulcers. Topical treatment for both oral and genital ulcers in Behcet syndrome may include local anesthetics to provide temporary relief of discomfort and corticosteroids to promote rapid healing in oral genital ulcers, right? If local anesthetic is indicated for relief of discomfort associated with oral ulceration in Behcet syndrome, before eating and performing oral hygiene, use lidocaine 2% viscous solutions. Okay, just to relieve the discomfortness and pain. If topical local anesthetic is indicated for relief discomfort associated with genital ulceration in Behcet syndrome, use lidocaine. Is triamcinolone. Okay, these are the options. Lidocaine, steroids, we can use triamcinolone, betamethasone. Okay, intralesion corticosteroids may be offered for intractable ulcers or topical pamicrolimus is an immunomodulated therapy used to treat recurrent genital ulceration in combination of colchicine for prevention. Data suggests it may reduce healing time and pain, but should be where I am. Combination therapy with okay, where are you? But should be limited for specialist use. For recurrent episodes of ulceration, the treatment course described above may be repeated. Okay, immunomodulatory therapy for oral and genital ulcers, colchicine. Okay, if colchicine is indicated for prevention of oral genital ulceration in Behcet syndrome, use colchicine. Oh, that is the same thing. Okay. Oral corticosteroids may be used for patient to treat for the treatment of severe oral genital ulceration. If indicated severe oral genital ulceration in Behcet syndrome, low dose start long-term therapy is recommended. Prednisolone. Then taper of 1 to 2 weeks. Okay, severe disease means the patient has recurrent. recurrent, and there are also eye involvement. When there it is always eye involvement and systemic involvement means thrombosis, DVT, or GI involvement. It's systemic systems are involved now in that case. So always give steroids. Steroids in exam, steroid is the safest answer. Steroids is the safest answer. Ophthalmic features management, very important. Urgent refer. First of all, urgent refer the patient to ophthalmologist. Management uveitis in Behcet syndrome must involve an ophthalmologist. Okay, patient who present with an initial recurrent episode of acute sight-threatening uveitis should be treated with high dose steroids, corticosteroids, and a TNF inhibitors are interferon alpha. As an adjuvant to systemic immunomodulatory therapy, intravitreal corticosteroid injection is an option for some patients with unilateral exhibitions of uveitis. Remember that this eye point is very important. But they have been asking just only the corticosteroid. But as an adjuvant to systemic immunomodulatory therapy, intravitreal corticosteroid injection is also an option for some patients with unilateral exhibition of uveitis. Okay, management of cutaneous features of Behcet syndrome, colchicine. Okay, arthritis, we will give colchicine as well. Uh, if the pain of arthritis is not settled with colchicine, low dose systemic steroids may be added. Okay. Acute pain and oligoarthritis may be treated with intra-articular corticosteroid injection. For more detail, using local corticosteroid injection, we have to see this. For resistant arthritis, azathioprine is commonly the first choice immunomodulatory therapy. No need to remember this, okay? Vascular features of Behcet syndrome, how we can manage it? Uh, okay, vascular complication of Behcet syndrome should be managed in conjunction with specialists. Treatment may include corticosteroids, immunomodulatory such as azathioprine, cyclosporine, and cyclophosphamide. Okay, these are the immunomodulatory drugs. Azathioprine, cyclosporine, as we know that. Arterial vasculitis in Behcet syndrome can lead to dilatation and aneurysm of medium and large size arteries. This complication may require combination of medical and surgical treatment and interventional radiological procedure. Medical treatment involves high dose steroids. For VTE, anticoagulant using standard approaches is recommended. However, as people with Behcet syndrome may have arterial aneurysms as well. Okay, neurological features, how we manage. Specialists, we have to refer the patient to. In acute phase of neurological phase, high dose intravenous corticosteroids are recommended. Okay, in neurological cases, we will give intravenous steroids. Okay, plus intravenous steroids should be followed by slow tapering of oral steroids plus an immunomodulatory drugs. Okay, GIT features, how we manage, definitely we will give the steroids. Okay. Okay, first we have to differentiate it from Crohn disease with the help of biopsy. Okay, remember that point. It's not really important, but this is for your information. So, refer patient with GI symptoms of Behcet syndrome, bleeding, suspected bowel obstruction, perfusion, urgently to hospital for surgical consultation. Endoscopically confirmed GI disease is usually managed with systemic corticosteroids and steroid-sparing immunomodulatory drugs as thiopurine, sulfasalazine. TNF factors as used overseas for intestinal features of Behcet syndrome. Typical treatment with systemic corticosteroids should be started in consultation with gastroenterologists who can assess the condition, extent, and severity of the disease. So that is all about Behcet syndrome. The thing is which you need to memorize it. Just remember. Forget about everything. Just remember that orogenital ulcers, oligoarthritis, mono or oligoarthritis, and the third point is uveitis. Uveitis present with painful red eye. Okay, painful red eye. And what is the treatment? Steroids and colchicine. Remember these two drugs. Okay. So now I'm going to show you the questions, recall questions, which they have been asking from last 1 year regarding Behcet syndrome. Okay. Okay, so a 22-year-old man presents with recurrent Recurrent oral genital ulcers and a red painful eye. 22 young age, right? That's what we discussed at 30s and 40s. What is the most appropriate treatment? Okay, because the eye is involved, so we will give oral steroids. Okay, oral steroids. Don't be confused that. It's very, very simple. Okay, now in the one recall they have giving us a triad painful sores in the mouth, that is orogenital ulcers. They never say the orogenital, but sometimes they used to say that. Recurrent ulceration on the scrotum or labia. Okay, scrotum in man, labia in female. Described as painful red painful eye, often diagnosed as uveitis. Okay, so uveitis or orogenital ulcers. And visual finding, images they provide image of eye provided in the exam typically shows red dye with ciliary injection and constricted pupils. Remember that ciliary injection and constricted pupil. Don't be confused with the other. They might confuse us with glaucoma. In glaucoma we have a mid dilated pupil. Okay. On one recall, identify this as a unilateral painful red eye associated with autoimmune disease, whatever. Okay, so Behcet, how we can make the differential diagnosis of eye? Behcet in uveitis, painful red eye, photophobia, small constricted pupils, ciliary injections. Acute conjunctivitis, we have red eye with discharge, right? With discharge, pupil size and light response are usually normal. Acute glaucoma, as I told you, mid dilated pupil, hazy cornea, elevated intraocular pain, and severe pain. It's painful red eye but not severe. Okay. Okay, in this recall, 2025, a patient presents with a history of genital ulcers and now returned with the eye problem and mouth ulcers. Okay, Behcet Syndrome, Behcet disease, right? Clear? A patient presents with oral ulcers, genital ulcers and bilateral eye pain of 5-day duration. Symptoms have been relieved with conservative management. Okay, oral ulcers, genital ulcers, bilateral eye pain for 5 days duration. What is the most appropriate next step? Steroids, definitely steroids, because eyes are now involving. Yes, oral steroids. Okay. Next scenario is 32-year-old woman has a 3-month history of painful joints, wrists, ankle, knees, recurrent oral ulcers, and rash on her face. The body studies shows leukopenia and thrombocytopenia. Okay, in this scenario, we have a 32-year-old woman, 3-month history of painful joints, wrist, ankle, knees, recurrent oral ulcers, and rash on her face. Oral ulcers are okay, arthritis are okay. Did we fill the criteria? What we have that rash on our face. We never read this. We didn't read this, right? The body studies shows leukopenia and thrombocytopenia. No, we didn't read this. Okay, it's most probably it's also related to what you call autoimmune disease, painful red eye, wrist, ankle, recurrent oral rash on our face, and leukopenia, thrombocytopenia. So it's most probably SLE. Rash on our face is most probably SLE. And in SLE we have recurrent oral ulcers as well and painful joints as well. So to be master in this Behcet syndrome, we have to have an idea of other autoimmune diseases like SLE, psoriatic arthritis, right? But at the moment, just remember that while Behcet shares oral ulcers and joint pain, the absence of genital ulcers and eye involvement combined with specific hematological abnormalities, leukopenia, thrombocytopenia, and a butterfly facial rash points definitely towards SLE. That is correct. That is correct. Clinical features, recurrent genital, we discuss. Epidemiology is very important, most common among the population along the ancient Silk Road, Turkey, Japan, Korea, and China. Remember that. If the patient with a non-inflammatory condition like ulcerative colitis, Behcet presents with red, painful eye, they require an urgent referral to an ophthalmologist to prevent permanent visual loss. Okay, another scenario. I think that's the same scenario. April 2026. It's a recent one. Okay, so it's not really tough. That is also the same one. Okay, so no need to go to the depth of the topic. Just see as every scenario is there. It's 2025. Okay, what you were asking before. A patient presents with oral ulcers, genital ulcers, and bilateral eye pain for 5 days. Okay, symptoms have not relieved with conservative management, oral steroids, right? So We have to diagnose it and then give the treatment. Okay, it's October 2, 2025. 32-year-old woman present with 3-month history of painful joints, wrist, ankle and knees. The recurrent oral ulcers and facial rash. Lab shows leukopenia and thrombocytopenia. That is SLE, right? Behcet most likely if they are genital ulcers and specific uveitis typically lacks facial rash and significant cytopenias. More likely if there is a facial rash, hematological findings, leukopenia and thrombocytopenia, we have to think it from SLE, right? Okay. So that is all. I just summarized that and I will show you the pictures. It's because we mentioned that patient has okay, these are the pictures. Oral ulcers, uveitis. This is what we called erythema nodosum. These are erythema nodosum. Remember that in Behcet syndrome we have these ulcers, oral ulcers, uveitis, okay, orogenital ulcers. So in this that I took it from med bullet, okay. Not med bullet. This what you call the I forget that. Just let me check which one. This application. Yeah, I think it's med bullet. Yeah, Behcet syndrome. So I took it from here. Okay, just clearly mention everything. Okay, a 35-year-old Middle Eastern man presents to his rheumatological for painful ulcers and genital ulcers. He reports that he also is fatigued, has joint pain and stiffness in the morning. He is currently sexually active with 2 women, but reports that all parties had sexually transmitted infection testing prior to engaging in any sexual activities. Physical exam reveals multiple abscess ulcers and genital ulcers. He also has palpable purpura on his lower extremities that is concerning for vasculitis. He is sent for additional body follow-up and given topical corticosteroids and colchicine. Okay, so that is all about Behcet syndrome as I discussed. Now, if you really need it, you can. Okay, classic triad, ulcers, genital ulcer, uveitis. So think about Behcet syndrome. Other clinical features, uveitis is bilateral retinal vasculitis, can cause blindness. We have to refer the patient. In skin, we will get erythema nodosum, papillopustular lesions, and pseudofolliculitis. CNS, we will get headache, stroke-like symptoms, and cerebrovenous sinus thrombosis. Vascular, we will get thrombosis, DVTs, SVT, aneurysms. Behcet, both clots plus aneurysm, we have to think about Behcet. Okay, but they never ask in the questions. Joints, non-erosive arthritis, knee, ankle, self-limiting. GIT, we have abdominal pain and ulcers, but we have to differentiate with the help of biopsy. No labs test confirm Behcet, only clinical, it's a clinical diagnosis. So oral ulcers, 0.2, genital ulcers 2, eye involvement 2. So a skin, CNS, vascular and pathology tests, 1 each. For more than 4 points leads to Behcet syndrome. It's very simple. Herpes simplex we have to differentiate. Investigation we have ESR CRP raised but no confirmatory test. Biopsy helps to differentiate Behcet with IBD, but that is they never ask that. Management is very important as we already discussed. Colchicine is the first line. Okay, and severe diseases eye, CNS, vascular, GIT. Main treatment is systemic corticosteroids, right? Immunosuppressants, thiopurine, cyclophosphamide, TNF inhibitors. So yeah, we will give immunosuppressants. Eye involvement, high dose steroids. Vascular disease, steroids, immunosuppressants, anticoagulants used, but caution if aneurysm present. Behcet for use, ulcers, uveitis, unpredictable vasculitis and ulcers, aneurysms, thrombosis, right? Young patient, recurrent mouth ulcers, eye pain, Behcet. DVT, oral ulcers, Behcet. Uveitis, genital ulcers, Behcet. Which vessel involved? Arteries and veins. Remember this point, okay? Young patient, recurrent mouth ulcers, eye pain, Behcet. DVT, oral ulcers, Behcet. Uveitis, genital ulcers, Behcet. Okay. So this is positive pathology test. They put the needle and then we will get the exaggerated response. Okay. So that is all about Behcet syndrome, and in June 2026 they confuse us with what we call, as I told you earlier, with psoriatic arthritis. So they, in this scenario, they give us orogenital ulceration, but and arthritis as well. Okay, and they didn't give us the eye clue, and then they try to confuse us with psoriatic arthritis. So to get a better idea, we have to read about psoriatic arthritis, because in psoriasis, remember that in psoriatic arthritis, we will definitely get arthritis plus skin changes. When there is an arthritis and urogenital ulcers means 2 points, right? 2 for orogenital ulcers and 2 for arthritis. I think we have 1 criteria. So in that cases we have to think about Behcet syndrome. Okay, but sometimes because in the stamp in recalls we don't have the full stamp, so they might miss that stamp. But yes, and these are all the recall questions which we just keep repeating about the orogenital ulcers. They confuse us with SLE, and they might confuse us with acute angle glaucoma, because red symptoms we have to know what is uveitis to be mastering that. There is no clinical diagnosis. Remember that steroid is the mainstay treatment. Remember that, okay? Whenever the systems are involved. So that is all about Behcet disease. And then we will discuss about all the June. These are all June recalls 2026. Okay, so we just cover all the June recall questions, and then definitely we will cover the previous month's recalls. Thank you.